All right, we're ready to get started. So again, good morning, everyone. Welcome to the second Rules Advisory Committee meeting for House Bill 3046 regarding mental health parity. I'm Lisa Emerson. I'm with the Division of Financial Regulation. I'm a senior health insurance programs analyst. We kind of want to launch into this next meeting. Our first meeting, we had the opportunity to do very in-depth introductions, and I just want to welcome all the Rules Advisory Committee members and interested parties and my division staff team members. And when each person, each of you participate, RAC members, feel free to introduce yourselves again. It might also be very helpful if RAC members and even interested parties that have joined by teams could, in the chat, put their name, title, and organization, just helpful for all of us since this is being recorded. Or do it, like when you raise your hand. It doesn't have to be done right away, just throughout the meeting. That'd be helpful. Another reminder would be that this meeting conversation is limited to the RAC Rules Advisory Committee team members and DFR staff, but there will be an opportunity for public comment toward the end of the meeting. So any questions before we get started? Okay, I'll do, and feel free to raise your hand if you have any questions. So I'll do a brief recap and then I'll hand it over to Cassie to dive into the draft rules discussion draft. But just as a recap, in our last meeting, again, we did some robust introductions and then we dove right into discussing aspects of the bill focused on Section 2. This phase of rulemaking will focus on Section 2, which is regarding the insurer reporting requirements for mental health parity. And so we went point by point through Section 2, and we're going to continue that discussion today. And you'll have an opportunity to, we'll be discussing the discussion draft of the draft rules. And we had a really robust conversation about the elements of each of those points within Section 2. And without, belaboring all those points, we're just going to maybe dive into that because that's what we're going to be discussing today, which is the reporting requirements. So without further ado, I will hand it over to Cassie and we'll get going.
All right, thanks, Lisa, and good morning, everyone. Appreciate you all joining to talk through this discussion draft, which really is just to prompt further conversation about where we need to add clarity for the reporting requirements and having kind of an in-depth conversation about what else is needed to really make these clear for all parties involved. The first part of the discussion draft is pretty explanatory. Usually most rules do include kind of a purpose and statutory authority. So it just references the rules, the numbers that we would be used. They are located in a similar spot to where our administrative rules for the current mental health law are located. And it includes the statutory reference, which right now is an Oregon law chapter, or 2021 Oregon law, 2021 Oregon law chapter 629. So that will get updated if it gets when it gets integrated into the ORSs and whatnot. Moving on to the next section, I know that there were some things that were required to be defined by rule, specifically geographic region. And then I think there were a couple items that came up in our discussions about partial denials and including a definition for that, as well as a time-based office visit. When we launch into discussion, we'll talk through if there's anything missing or if these need to be changed. But Those are the definitions that came to mind most immediately, and we'll talk further later on about what needs to be added or changed or removed from the definitions section. Moving on to the form and manner for the reporting, and this adds some clarity to how the reports will be received and provide some additional information about the data elements, some clarity around that. The first couple points for 1 and 2 are pretty general about the requirement for these reports to be submitted to the department by March 1st of each year, and that submitting that information is for the previous calendar year, so that gives the time frame for which the reports are to be, the data for those reports are supposed to be included. And then also adds some language about submitting it in an electronic format that is specified by the department. We have a team that's working on developing a template. So I think that will be another discussion item for this RAC, and just sets forth those standards within the rule. Starting with number 3, it talks about the start date, which is next year, March 1st. It will include the following information, and this is all of the federal data elements that are already covered. What we did here was to, I think some of the members talked about there being, some standardization around what's happening for the national reporting, and making sure that we try to make this as efficient as possible, especially when there's multiple types of reporting. So the way that this is framed is that the following information will be submitted in accordance to standards that are posted on the department's website. So this gives us some flexibility to make sure that we're staying consistent with whatever the reporting template is for those federal requirements, and that we can more easily kind of tweak it if it does change over time. And we'll definitely talk through if that makes sense, or if we need to add any additional language to that section. Underneath that, it just lists the data elements that are relevant to kind of those standards, which are all of the federal ones. Moving on to the next section. So this is sub B. Karen, if you want to keep scrolling down. This section includes all of the data elements that are more quantitative and are also only in the report until January 1st, 2025. So the statute does a funny thing where we have specific data elements that are required to be reported up until January 1st, 2025. So this gets into a little bit more detail about those, and I tried to integrate the feedback that I had written down from our last meeting, and apologies if I missed anything, but that's part of our conversation today, is to make sure that we look at some language and make changes where needed. So this includes some of the information about denials, and specifically it was brought up about partial denials. Talks through the percentage of the claims that are paid to providers, as well as the medium maximum allowable reimbursement rate for the specified billing codes. It includes some specific information about the time-based office visits for reimbursement rates. And then there are the final ones about compliance and other data information. And those pieces, I think, would love to get feedback from the RAC about what can be included in those sections. And that kind of concludes the overview of the discussion draft. Before we kind of move on, one thing that we can discuss later on is, it occurred to me after I sent out the discussion draft about these data elements that are specific to be included until January 1st, 2025. I think there's a couple different ways that we could do this. We could include the specificity of like how to report it in rule, or we could include it on the department's website, since it is kind of a time limited data element to be included. And would love feedback later on when we dive into this section about if it makes sense to put that specificity in rule or to have that as guidance on the department's website. So I'll just put that out there for you to be thinking about when we get to that section. Any questions about just kind of the overview? We're definitely going to dive into each of these pieces for pretty much the rest of the meeting, so we'll have time for robust conversation, but want to pause for a second and see if there were any questions or comments, just kind of overall about this first kind of discussion draft. Oh, Lisa, go for it.
One thing I forgot to mention is I just wanted to thank those that submitted helpful information and tools to assist this rulemaking, Tim and Melissa. And if I'm overlooking anyone else, I apologize, but that's very helpful for this process. So I just wanted to mention that. Thank you.
All right. Yes, thank you very much. Let's dive in. We'll start with the definition section because I think that is one of the first places. I don't think, unless anyone has any issues with the purpose and statutory authority, which I don't think there will be any issues with that section. Before we launch into the specific definitions, are there any terms that are missing that should be defined, or any kind of big areas that you think we would need clarity in defining in this rule? Melissa.
We did have a question about whether whether median maximum allowable reimbursement rate should be specified anywhere more clearly. And then the other piece, which I included in my memo, was that complicated bit about the incentive payments versus situations where higher rates were negotiated because of a size of a practice or a large market share. Yeah, just thoughts on whether that needs to be specified anywhere.
Yeah, I think we heard from one other individual about providing more clarity about the median maximum allowable reimbursement rate. So I think that is something that we'll probably want to include clarity on. I know it is defined in the statute, but if we do need to include kind of some further information about to provide that clarity, we can definitely consider that for sure.
Yeah, and then, I think that I'm sorry, I apologize. No. I think the incentive payment part might need more clarity because even though it was in the bill, it doesn't expand upon what that part means.
Yeah, so it could be a definition about what, when we refer to incentive payments in the median maximum allowable reimbursement rate, what does that exactly mean? And what does that include or exclude?
Yeah, that's what we were thinking. That's why we addressed it in the memo, because we, when we took a look at it again, we thought, well, people are probably going to have questions about what this means.
Great. I will add that down for us to include. Are there any thoughts about what else should be included in like the incentive piece of that? Or I know there was a question about what other kind of fees or other payments should be included in the definition of the median maximum allowable reimbursement rate. Are there any other thoughts? All right.
Well, I'm wondering, Melissa, if you can explain a little bit more what you mean by parity penalties for paying more to meet outcomes goals and kind of how that fits into the construct.
Yeah, sure. Let me just pull the memo up over here so I can look at that section. Yeah, you know what we're trying to convey here is that, you know, so in situations where perhaps there's a provider or provider group who are doing extra things to provide more value or or to reflect a higher level of performance, we don't want insurers to essentially be penalized for paying those providers more. And so that we want to make it clear that we support those situations where providers are doing more and are therefore being essentially, you know, reimbursed at a higher rate because of that. Does that help clarify that?
I think so. So then those higher rates would be included in the MMAR that we would report. Is that right?
Actually, I don't know if you had a chance to take a look at our memo, but that might be helpful because we tried to address this in a paragraph, and this is why I was saying this may require a little bit more clarity and to actually have it written in, is that we are okay with those incentives being excluded that are because we don't want that to essentially penalize insurers. And so if there's a situation where a provider is, again, you know, doing more and being reimbursed at a higher rate for that, that can be excluded or possibly parsed out. Last time in the last meeting, we had talked about how there might be like a base reimbursement rate, but then maybe a provider is, I have no idea what you guys are doing, so I'll just make up an example. Maybe a provider is having all of their patients, you know, fill out extra measures and, you know, and then because they're doing that consistently, you're saying we'll pay you 3% more because you're doing these outcome measures. We're okay with that not being included because that's going to, you know, sort of provide an inflation that is based on extra work that provider's doing. Now, so that's in the exclusion part. And then if you look in the second part of that paragraph, we specify that what we want included in the MMARR calculations are situations where providers or provider groups have negotiated higher rates simply because they're a large size. Like, you know, we are a huge group practice, we have a large market share. Because of that, we negotiated a higher rate of reimbursement, and we're not really doing anything extra to get that higher rate. We're just large, and we would like that included in the MMARR calculations.
Tasha.
So first of all, sorry for being late. I had a conflict, which never happens on Fridays, except for this Friday. But I did want to, kind of in response to Melissa, that breakdown, for a data call or for an exam that I'm doing right now, I have it broke down into separate fields. And how we've explained that is that there's like a total paid for the claim, and then there's a separate column that we're having reported out on to try to capture this information. That is a total payment. So there's a claims paid, and then there's a total payment to capture any kind of incentive payments or anything like that. So I'm sure Spencer's on this call, but I was just kind of listening to what you had to say and to help folks visualize how we might be able to pull that out. That is something that I've been sort of asking for in other contexts, and that's something I'm playing with, and something that I can work with the insurers so that we kind of get right, but we can pull that out.
That's wonderful, because we're talking about this not exactly knowing how this can be done, because we obviously don't have the information of how this gets done, and we were hoping that the insurers could help with that. But that's great, Tasha, that you're already have found some way to sort of parse those things out. So.
Great. Any other comments about the median maximum allowable reimbursement rate or incentive fees and how we define or think about how that is reported? Okay, moving on to the definition for geographic region. I don't know if anyone has issues with this, but it is just what we use for the geographic divisions that we do for the individual and small group markets. I did send out a map that it was included to show you those divisions. Any comments or questions about that? Okay. Moving right along to the definition of a partial denial. What is drafted is that it means a denial or non-reimbursement of certain conditions or parts of the claim that is submitted for services provided to a covered enrollee as specified in the plan documents. I don't know if anyone has a better definition for a partial denial. I'm happy to get feedback. And Dan, you have your hand raised.
Thanks. I would suggest replacing the word conditions, because when there's a denial, it's not the condition that's denied. What's denied is the service or the supply. Services or supplies are the words that we use in our handbook. If there's a better term, then that would be fine. But I think services or supplies might work better in this spot.
Yeah, I appreciate you providing an example of the language that is used, so we make sure that that is accurate to what kind of language is used kind of on the back end regarding claims. Yeah, Gary.
Hey, I don't know if it's relevant or not, because I brought this issue up before with the partial denial, and I did some work internally with this. And for the most part, in the mental health space, we're not going to see partial denials. What I've learned is that a lot of these claims are usually done at a pre-service level. For inpatient, we get notified, we look at the treatment plan, and so there's no denial of a claim after the fact. If it is, it's very rare. And so what I want to know is, if we're looking at these partial denials, is it going to be pre-service, post-service? Do we need to clarify that? On the physical health side, it's sometimes you'll see partials, but on the mental health, that was the only issue that kind of came up with me is, do we need to distinguish between pre and post-service? Do we concern ourselves with that level of detail in the analysis you're trying to perform?
Are there any thoughts from the RAC on this? I think one thing just to keep in mind in terms of like this whole thing is we can go through it and see what works. And then also when we come back to continue the rulemaking, we can adjust things after we've kind of learned about, actually doing the whole reporting process. I think also helps with like learning where things need to be adjusted and where we need more specificity. Bennett, I see that your hand is up. Oh, you were on mute.
I have seen partial denials in behavioral health. Often somebody asks for a certain number of days or a certain number of services, and there's fewer days approved than requested. So I think it goes to whether we're talking about whether it's in advance or post hoc or whatever, but I have seen this with some degree of regularity, so I think it's important. And I do recall, maybe we'll get to this later, that we were going to get some sense of what, because at least I didn't have a sense of what partial approvals or denials meant on the physical health side as much, and so what the comparisons would look like.
This is,
Let's go with Dan, and then we'll go to Tim.
On the pre and post issue, I'm not sure that it would really provide useful information to make that distinction. So I would suggest just rolling them all up into the total number of denials. I mean, I don't see a problem with reporting them pre and post necessarily, but I'm not sure that that serves a purpose.
All right, Tim.
Sure, yeah, and I don't want to overthink this, and maybe it's too granular to have an additional definition for partial approval. Maybe that's not necessary. I'm just thinking this out loud just a little bit, just from what Bennett said. Is because a lot of times in the behavioral health side, you will see the number of days requested. It's say a prior authorization or particularly concurrent review. Maybe there's 5 days requested, but there's only 3 days approved. I don't know if that shows up as a denial or if it just shows up as an approval. Maybe some companies do it differently than others. Or you might have a certain level of care that's requested. So for instance, it might be, partial hospitalizations requested, but it ends up being approved at intensive outpatient. So I personally don't know how different companies might classify that. So that could go as either a partial denial, or it might not necessarily be a denial. It might be an approval, partial approval. Or I might just be overthinking this. I mean, maybe just having just one definition is fine. And everyone will probably know how to report it. I'm just thinking that maybe it's just classified maybe sometimes as a partial approval instead of a partial denial. So,
Gary.
no, I agree with Tim. If we want to roll up partial denials into a denied claim, then I change that definition from partial denial, say denial includes partials of, no matter to what degree, if we want to simplify to get to whatever analysis you want. I just don't know how significant it's going to be. I don't think there's a lot of them. They do occur, and it may help us instead of getting too much into the weeds, trying to divide between physical health and mental health. And so I agree with with Tim, if that's what he's putting forward, is a single definition where we include partials under a complete denial. Great, if we don't think it's going to affect analysis or outcomes. That's just my thoughts.
All right. I think Heather is next, and then Bennett.
And I just wanted to affirm with Tim and I think Ben, the previous person there, that I think having it under the regular denial, as long as it's getting recorded, because depending on the situation, it can either be a partial or a full denial. And I think just to capture that data in one succinct place is very useful, because where one situation it might be a full, another it might be a partial. So I think that that's a very wise comment.
All right.
I think you wanted me to go next. I may be overthinking this too, but to me, there's a difference between somebody requests 5 days of hospitalization gets 3, and somebody that's, as Tim was saying, requests hospitalization gets partial. Because in the hospital situation, you haven't actually denied anything. You just have to review it again sooner than you may have wanted to. And that to me is a whole different thing. But I've been in some situations where even that required the notices to be sent out and everything. And I think it might be worth making that kind of distinction. What kind of partial denial is simply going to require a little bit more frequent review than other kind of partial denials.
Dan.
Just speaking from our perspective, the situation that Bennett just described where maybe 5 days are requested and we authorize 3 and request a review at that time, we don't treat that as a denial. We don't record it as a denial or send any kind of denial notice because those additional 2 days may yet be approved. So that's just how we handle that operationally.
And Gary.
Yeah, I support Dan the same way. I don't think we necessarily record it as a denial if we say 3 days instead of 5, because it always depends on medical necessity. If they get to that 3rd day and the doctor comes back to us, we can review it again.
You're muted, Cassie.
Man, you'd think I'd know by now with how many virtual meetings. We'll go to Tim, and then I think just in the interest of time, we'll keep moving through so we can get through as much of the discussion draft as possible. So Tim.
Yeah, thanks. And I agree with Bennett, Dan, and Gary. I spoke too cavalierly there. Requesting 5 days and having 3 is very different animal than requesting, inpatient and then getting approved a partial hospitalization. One is where you don't get what you were looking for. The other just requires you're going to have to do it again a little bit sooner than you wanted. So I agree. Those should not be lumped together as the same thing.
All right, Gary. Nope, you're good. Okay, awesome.
Sorry, I just got to take it down.
It's all good. Thank you all for the robust discussion. I think we'll take your feedback and kind of relook at what we do for the definition for denial and including partial denials within that definition. So moving on to the time-based office visit, I know we had some conversation about which billing codes are included within this definition. The approach that we took was to kind of define what a time-based office visit is, and then later on in the rulemaking language to make it flexible that it'll be specified on the department's website. So that we would have kind of more of an external reference to those billing codes rather than putting the billing codes into the rule. But does the definition that is listed, does that make sense? Is there anything missing? Is there anything that should be changed to clarify that further? Melissa.
This may just be a small thing, but I just had it flagged. The face-to-face piece with our new telehealth law, does that not allow telephone, which would only be audio? So that would just be something to look at because we have that new law that just got passed.
That's a very good point. Yeah, I've had phone appointments myself and should have caught that. Yeah, we'll make that adjustment. Okay, anything else with the definitions section? And obviously, as we kind of work through what we have and then referencing the rule or the law, if there are pieces that we need to define later on, that we can receive that feedback and definitely take that into consideration. All right, so we'll move on to, I think, the more substantive section of the discussion draft, which is about the reporting requirements. 1 and 2 are really just kind of logistics about when the reports are supposed to come in and how they are to be reported. Any comments about 1 and 2 under form and manner? Gary.
Hey, in regard to Sept 2, the format, I know the carriers, we each have our own different variations of this as we're working through it because of the, you know, the state and federal level. I have a little concern if Oregon's going to come out and say one specific format. We do operate in different states. And so I know some other states have prescribed their own formats for those NQTL templates. And so I just asked that there be a little flexibility. This, you know, say Oregon could put one out, but you know, it's one of those if you know, a carrier is choosing to use another type of template format but the same content, that would be acceptable. I think we just got to take that in consideration because I think most of the carriers do operate in different states.
Got it. That is helpful. Thank you. Tasha.
Gary, this is Tasha. That's something I'm working on, that template. That's something Spencer and I are kind of working on and looking at. He's working on the more data component. I'm working on the more narrative component. So if there are things, this goes for all insurers, if there are different states that you want me to look at that have a template, let me know. So far I got, I cannot remember, my apologies. There was a draft sent around that either the U.S. Department of Labor or NAIC kind of put together a reporting template on those fields. I looked at that and I was leaning toward using that. But if there's something that, some way that can be amended, please let me know.
Okay, hey, Josh, we're looking at the Chicago or Illinois Department of Insurance. We really like their templates. We've kind of done some outreach and gather information that seems to be a good starting point, especially with the feds. That type of format seems to be good. So that's what I'd offer out there is, you know, we can at least use that.
Okay, perfect.
Jen, I believe you're next.
Hi, thanks. And Gary, the S is silent as a native Chicagoan, so it's Illinois. But I want to actually agree with everything that Gary has said. And the one, the most important feedback that I've been getting from our team here at Providence is that we want flexibility on that report because we've already started building using data components that are in your report for the federal reporting requirements, and you know, insurers in multiple states would really like that flexibility. Also, keep in mind we have the federal report, so it's easier, it's less resource intensive, and allows carriers sometimes to provide more information than you're asking for, but gives us that flexibility to submit the reports as are required in multiple states. So if we can have that flexibility, and you know, the one thing I'm thinking of, Tasha, if you're working on a specific template, like that's something different necessarily from the Word document that we've seen. We would really, if you're going to go with a specific template, we'd really like to be able to review and comment on that, because again, we've already started building our report, so we'd like that opportunity to continue using that report if possible. But if not, like let's look at the template specifically and comment on that, because I think that's going to be really helpful for a carrier.
Yeah, Jen. I think. Sorry, I'm losing my voice today. I think that. I'm going to look at the Illinois template specifically because that is the one that Gary just mentioned. But if there's any others, or if you kind of want to send me what you're internally looking at, please send those to me, because that is something that I'm contemplating. And if I can streamline by using an existing template or something like that, I think I'd prefer that. So.
And I will say that we have done some outreach to Washington and are in touch with Pennsylvania. Like, I think there's several states that have been working on this. And so I think if we can streamline it as best as possible, we would definitely consider doing that. So if there is any additional templates out there, please send them our way, because I think one of the steps in this process, it will be to look at what we've developed in terms of a template so that we can talk about it as a RAC. Tim.
Yeah, so I think that having worked on both the Illinois template and also what was circulated to the group, I mean, they're basically the same thing. But the only, and I would say I support the flexibility. I don't think that anyone's harmed by using, let's say, the Word document that was submitted, or instead submitting the Illinois document. The reason, so the Word document that was circulated, I do know there are several states are using that right now. I'm not sure if Washington's started using it yet, but I know there's a number of East Coast states that are using it. The only reason I slightly prefer that is because it does have, explicit, references to the frequently asked questions number 45 the Department of Labor issued that gives guidance about what is and what is not a sufficient comparative analysis. It doesn't say you have to meet those standards, it gives guidance. I think that's helpful, and sometimes having reviewed some of these comparative analyses in the past, sometimes you'll have someone that's filling out the analysis that might think something's appropriate, but it actually probably isn't. So that guidance can be helpful. And then also, the one thing that I slightly prefer about the Word document, but again, I don't think it really makes a big difference, is that the Illinois template has reporting for behavioral health, reporting for medical. I like the Word document has just combined, because really the point is a comparative analysis. So in other words, you're not listing mental health and substance use disorder stuff. You're not listing medical, surgical stuff and saying, take a look. You're supposed to do the comparative analysis, and you're supposed to explain, and this is within the statutory requirements, you're supposed to explain as the issuer of group health plan how it is that your comparative analysis meets the requirements of each step. So, but again, I think flexibility is fine. I mean, I know people have been working off the Illinois template. I know that there's been some other templates. I support the Word document just a little bit more, but I don't think it's the same content in the steps. So I don't think it's really that big of a deal. I just prefer the Word one just a little bit more, but not a problem with the Illinois template.
I think one of the things that would be helpful for at least me is if someone, one of the insurers who's using the Illinois template can send maybe a blank one to us so that we can take a look at how that looks different than what Tim sent. I think that'll be helpful for when we're kind of reviewing, at least, generally, the template should follow these guidelines and have that as an example. Any other thoughts about the sections 1 and 2 under form and manner? Lisa?
I was just going to mention that we've been doing a lot of research. We've been real busy, and I did flag that Illinois format report. So I do have a link to it. So no one needs to go to the trouble to send it to us. Just want to let you know.
Thank you, Lisa, for being so on top of it. And we'll definitely take a look after the meeting and get you all feedback next meeting about that. So moving on to section 3, which is about the annual report. Sub A states the following information shall be submitted in accordance to standards posted on the department's website that are in compliance with the federal reporting. This is an attempt to try to make it streamlined, like many people have said, that there are the federal reporting requirements, allowing the flexibility for that kind of either the template or how it's submitted to be, adjusted over time. If, for instance, we start reporting using one of the templates and decide that we need to make some adjustments. I know, Tim, that you sent your document. I don't know if and you already kind of sort of started explaining it, but I don't know if you want to provide any additional kind of overview or information about how that works or how you've seen it work in other states.
Sure. Yeah. So that document was something that was presented to it. Full disclosure, I created that document and I presented it to the NAIC. I presented on a regulator-only meeting in August, just because I work with a lot of state insurance departments, so they let me into the club. And that's been used now in a few. I can't say which states, but there are a few states are using that document right now. And really all it is it's an attempt to just take the text of the statute, the federal statute, and then just provide a word format for each classification of benefits, because some of you may have seen some Excel spreadsheets that collect this NQTL information, and I'm guilty of originally creating that. And that's a horrible way to submit information that's mostly narrative in nature, putting it in an Excel sheet. And I realized that from the first state I collected the information and looked at it, it was a nightmare for me, and it was also a nightmare for the insurers that had to actually fill out an Excel sheet. So I'd say just don't use an Excel sheet. Whatever you do, don't use an Excel sheet, because that's for the stepwise stuff, because that's really hard for everyone involved. But it's just, again, it just takes the text from the statute and then just fills in the relevant guidance underneath it from the FAQ 45 released by the tri-agencies in April. Several states use that. That is now on the NAIC's regulator-only web portal for regulators to download and use. And I know some of them have been doing that beyond the ones I've been working with. I think for the Department of Labor, they are not specifying a template right now. They are letting plans and issuers really submit in any format they want, which I think is fine. I think you're seeing some use the Illinois format. Unfortunately, some have used formats that are outdated that are just not appropriate for the stepwise process. Some have submitted things that are more along the lines of essays. I think the Department of Labor will probably move towards a particular template, but I would expect the states to lead this. I would think that you're going to see something from the NAIC that other states start using before you'll see the Department of Labor say. In fact, I'm pretty sure the Department of Labor doesn't see it as their job to create a template for this. Maybe they should, maybe they shouldn't. So I think you're going to see this be sort of more NAIC state regulator to state regulator driven. But again, flexibility, as long as the content of the steps is faithful to the statutory requirements, I think that's the most important part. Using some sort of template that does not adhere to that, I think that's when you get into a problem. But as long as, whether it's this Word document that's been circulated that some regulators using, whether it's the Illinois document, which I worked with the Illinois working group that created that. I worked with the insurers there, this guy David Chilcutt from Epstein Becker Green. So, you know, I had input into that document too. So I think it's a good I think they're all good documents. I think so. It's not a big deal. I think the Word format that is put forward here, obviously I'm biased, you know, it has a little more color in terms of the guidance from the FAQ 45. But again, this is not a purity test here. I think the Illinois format's fine as well.
Jen.
So I just want to thank you. I just wanted to ask, so are you guys definitely going in to create a specific template that insurers must use, or is there going to be that opportunity for flexibility? Because I'm wondering if maybe we should then take the Word, if you're going to use that Word document, should we take it and edit that and modify it to how we've done it? I mean, I'm just trying to figure it out, because if we're going to give flexibility, then do we have to use the DFR template, or can we use our own? What does that mean? Because we would like that flexibility. We think our report's better.
So I think that from our experience at the division working on the network adequacy reports, initially we had allowed carriers to do each their own template or own kind of reporting format. And what we found was that did not allow us to do enough of a comparison. And so what I did this last year, as you know, Jen, and as the other insurers know, I got a lot more prescriptive, and but I still allowed quite a bit of flexibility in how that came into me. So that is what I was going for again. Is to be very prescriptive in my guidance to you as insurers, and then allow you to determine what format that's in. So that's what I was going for this time. I don't know if that is better or worse, but I do still want to, if there's any particular template that anybody's using, I do want to see those. I'm at this point just collecting information and trying to make my guidance to you guys the best that I can. So
that's great, Tasha. I just following up with you on that. I just want you all to be clear on what we can and can't do in terms of being flexible. Like, so if you're going to give us all the requirements and say, go for it, then that's great. That would be perfect. But I want you to make sure that it's clear that we can do that so that we're not non-compliant, or we are compliant. Sorry for the double negative.
Yeah, no, you're fine. I gotcha. And like I said, once I see the templates, I'm not really, especially now hearing that each insurer might be doing kind of their own thing right now, and wanting to take into account what you might be doing for other states. I would really like to see that first. So I'm not going to make any commitments right now about the level of flexibility, but I'd like to see that and just kind of learn from my past experience so we can get the best possible.
Cool. Thanks, Tasha.
Yeah.
Yeah, and so I'm hoping that the language that we have in the rule about following standards on the department's website will allow us to provide that specificity and adjust it if we need to over time, since this will be an annual report, instead of having to open up rulemaking continually to like make little adjustments to standards or whatnot. Are there any issues with going that route for this section of the report that does follow the federal standards? All right, hearing none. Any other comments for this specific section under sub A? The categories listed below are just the data elements that are required by statute. So there's not any like additional language underneath. Okay, so we'll move on to the second part of the report, which is the additional information that is required in the reports until January 1st, 2025. I mentioned this when I was going through the overview of this discussion draft, is that there's a couple different routes that occurred to me, thinking about how we go about this. So in front of you in the discussion draft is adding that specificity into rule and providing kind of that guidance. Another route is that since this portion of the statute does sunset in 2025, we could simplify this and just do something similar, that the reporting elements will be submitted to the department in accordance with guidance on the website, and then include this information in that guidance. Any kind of initial thoughts about the approach that we take? Gary.
Yeah, I support having this in the rule. It's very specific. I think if you put it on the website, it allows it to continue on. I would support that being more or less a data call from the state. If if you just put it on the website and you don't specify the time in here, I think that it just opens up where it can continue on. I'd rather have those as data calls. I like the rule where it's specific, it's tied to this bill, and we can show folks that it's, this is what we're doing, this is why we're doing it.
Jen.
Yeah, I would agree with Gary. Let's keep it in the rule. Let's keep it specific, and then, because it has the expiration date, you can leave the rule in there, but then we know that it's not a requirement after 2024. And I also think it would just be confusing if it's on the website after after the authority expires.
Yeah, thank you both for that. It was just like a thought that occurred to me that we could make it more simple and have it just as guidance on the website, but it sounds like at least there's some consensus around keeping it specific into rule, which we can delve into all the specifics that are already outlined. All right, so moving on to the denial information, I think we talked about, the definition of denial above, but this sub I basically just specifies that it should be for both full or partial denials. And I think based on our conversation above, I want to adjust this so it's a little bit more clear that we mean that it's a combined, number or percentage of that is inclusive of both full and partial denials, not that we want full and partial denials separated out. Is that kind of an accurate understanding of our previous conversation? Are there any concerns with that? Okay, seeing none, we'll move on to the percentage of claims paid to in-network providers and out-of-network providers for both behavioral health benefits and medical and surgical benefits. I think one of the questions that I had was, does it make sense to include partial claims if we talk about partial denials above? Does that make sense in the context of behavioral health benefits and how they're paid out, or is it mostly just in the denial space that this kind of partial denial happens, so there wouldn't necessarily be a partial claim as like the inverse of that? Dan?
No, I don't think the concept of partial claims makes sense in this context, because a claim is incurred from a provider. The claim is always, the whole claim is connected to that provider.
Thank you for that clarity. And it's probably me showing my inexperience with actually handling claims directly. So I appreciate the feedback. I was just thinking, like, there's denials and there's claims, and they might function similarly, or maybe they don't. So we'll make that adjustment if other folks don't see any concerns with that. All right. Seeing or hearing none, and I will caveat our whole discussion. We will, at the end, ask for you to submit any comments after the fact, knowing that if you have time to, think about this or send this to your teams and get feedback, we'll definitely want to include that. So this is by no means the only time that we can talk through comments about all of this. All right, so moving on to the next sub 3. The median maximum allowable reimbursement rate for billing codes for time-based office visit as specified on the department's website. So this is kind of getting at some of that flexibility about the different billing codes that could be used for a time-based office visit. One of my questions, I guess, to you all is, how do these billing codes change frequently, or are new ones added? Because I think there's, a couple different ways we could go about framing this. We could specify the billing codes in rule, or we could just have them referenced on the department's website if there are changes made frequently or semi-frequently. But if that's not the case, then we can think about putting them in to rule if that's something that would be helpful. Melissa.
I can't necessarily comment on how often they get changed, but they do get changed. So, I don't know if anybody has the inside scoop on whether any changes are coming through. I don't think it happens often, but it has happened. There was a big overhaul of the mental health, the psychotherapy specific office visit codes years ago. I have no idea if anything like that's coming down the pipeline.
Dan.
I don't have any insight either into whether anything is coming down the pipeline, but CPT codes do change, as Melissa said, and I mean, you never really know when it's going to happen. And so I think it would make sense to keep flexibility in that rather than write those specific codes into rule.
Gary.
I agree with Dan. I think if you can, identify the CPT codes on your website, so we're all reporting the same, because they do change. I don't have insight to, the future. If you put in a rule, I think it's going to get messy when we don't need to. So I support, if we just keep it on the website. If the division says, as of a certain date, these are the codes we use in populating the report and move forward, great. And that helps. Otherwise, each carrier may, be doing additional CPT code stuff. Who knows?
Bennett.
I may be getting lost in the weeds here again, but picking up on Melissa's comments about large groups negotiating higher rates, I'm wondering what the data points are, whether you're going to consider if a group with, say, 100 providers negotiates a rate, if that gets counted one time or 100 times.
Dan.
The way that I would envision that, the way I think typically these kinds of reports are, is it's per claim. So a larger group is going to have more claims that get counted. So would be represented proportionally in that way.
Melissa.
I don't know if this is something maybe Tasha would have insight into, but I'm unclear on this as well of whether how that MMARR is going to be calculated, if that's coming from sort of claims submitted data like the way they did it in the Milliman reports, or whether that's more about this is what this specific provider's maximum allowable is for in general. It just depends, I suppose, on what kind of data DFR is going to be asking for from the insurers.
So I'm going to try to answer so I'm going to try to repeat your question back so I make sure I got it right, first of all. So your question is, for the maximum allowable, are we looking at that on a per claim basis or a per provider basis? Is that what you're asking?
Yeah.
Okay. So how I understand maximum allowable reimbursement amounts is that, and this could vary from insurer to insurer, but it is my understanding that this is how it's done. There's a maximum allowable reimbursement amount that's assigned to each provider for a particular subset of claims or of CPT codes, I guess. So for a lot of insurers, it's my understanding that it's like for all of their CPT codes for a given line of medicine, so like psychiatry or mental health, all of that would be based on, let's say, a percentage of Medicare. And so all CPT codes for all providers would be based on that. Some insurers break that down and say that there are different allowable amounts for different provider groups, but it's once again bundled into like a host of CPT codes. I could be wrong on that. And once again, I don't want to speak for all insurers, but that is my background and past. So how I would look at that, or how I would want that looked at, I guess, is we would analyze it for the maximum allowable for both the provider. So we would look at, what providers we're looking at, but it would also allow, or what providers were being paid, or what that maximum allowable is set at. But it would also allow us to see if there were any differences for particular CPT codes because of how it's broke out. That is my experience with it. Gary or I know Jen had to drop off. Any of the insurers on the call can tell me how they do it, if they do it differently, or if I've got that backwards somehow. But that is my understanding.
Well, oh, I'm sorry. Sorry, Gary. I was just gonna say, like, so use me as an example. Like, I'm one provider, and so for 90837, for whatever carrier, my maximum is XYZ. That if it's just per provider, that would be counted once. If it was per claim, then they would have to count it whatever hundreds of times I happen to bill that code per year. And so that's the differentiation. You know, I guess the way I understand it is it's per provider. And to Bennett's question, if there's a group practice that has 100 providers, I would hope that it would be counted 100 times for each provider.
Okay, I see what you're saying now. Okay, yes, it would be counted 100 times for each provider in that case. Yes. If there's a practice with 100 providers, to your example. But Gary or any insurer who's on the phone, once again, I'm not an expert in any claim system in particular.
Hey, Tasha, this is Gary. I think it's going to be, you know, what answer are we trying to get to? Is it usage? Is it just the rates that are available? Because we contract with people that may never submit a claim to us. So I think that's kind of those questions is in your analysis, what are we trying to get at? Because like Melissa said, we're going to get skewed numbers. A large facility is going to have, you know, far more claims and carry far more weight. These smaller independent providers, and that could skew your numbers. So, I mean, if you want to do incurred claims, that's where you're going to get the weighting problem. If you look at just pure contracted amounts, yeah, but a lot of those may not be in use. You know, if our memberships only want to do certain, that's why it's a little bit of a challenge here to try and find that equal, you know, answer. That's my thoughts.
Dan.
So to come back to Melissa's example, if she submits, say, 40 90837s, in my experience, we would report those 40 claims for you. And if the person next door reported 2, then we would report those 2. We've got, we've got the infrastructure to do that kind of reporting. I don't know if we even have the ability to say, okay, let's pull out all of the contracted providers in our system and what the contracted rate is for that. I don't know how we would do that kind of a reporting, and don't recall having seen that kind of reporting in the past. That would also, like Gary said, you know, include providers who may have died 15 years ago, but the contract never got turned. So I think there would be some weird looking data in there if we went that way.
Melissa.
Gary and Dan, I very much appreciate you giving that information because I wasn't sure how that data was going to get pulled, and I actually like hearing that it's going to be pulled from the incurred claims, as Gary said, and I think we are interested in you know what is actually being used rather than, like you said, a provider technically would get paid such and such for a code that they never bill. That seems like it's not going to be as relevant to us, because I could understand that if you have a large practice, you might just as a whole just say everybody, this is what everybody gets paid, but not everybody's even, you know, maybe they're a specialist in a different area. But that definitely is something like good information to have that we can think on. Thank you for providing that.
Yeah, thank you all for this. I know I've learned some things, and I'm going to take some stuff back to our team to think through in terms of how we you know, I think going back to our previous conversation about how we further clarify what we mean by median maximum allowable reimbursement rate and how we can make that really clear in the rule so that everyone's using the same, you know, basis for how that calculation happens. Moving, Dan, yes. No, you're fine.
Thanks. Just one more comment on 3, the median maximum allowed rate for build codes, blah, blah, blah. I'm pretty sure what we're really looking for is for in-network providers. And so I think it would be useful to specify that in that subparagraph.
Tasha.
Yeah, I hate to be a pest, but I have a follow-up question for Dan and Gary. One of the questions that I'm thinking on kind of the periphery of this report is on the network adequacy piece of ensuring that there's enough network providers. So for mental health services. And so one of the things that kind of registered with me is that there might be providers who have like a maximum allowable reimbursement rate in the system or who have a contracted rate in the system, but haven't had any claims. That may actually be something that we're interested in seeing for like just for collection purposes to help us understand the data. So I don't know if that's something necessarily that I'm prepared to go into for this year, for this first reporting year, given the timeline that we have. But I do kind of think we should circle back to that at some point. So that was it. So I'm gonna go back on mute. See you guys.
Okay. So moving on in sub 3, there are 2 kind of subsections there that specify in number 1, and I guess this is part of that further clarification of how median maximum allowable reimbursement rate is reported to include the range and then the median absolute deviation, which is that measure of variance, I think, Melissa, that you put, or if I got it wrong, we can change that. Any thoughts about those 2 kind of additional pieces? So reporting, we would report the median and then we'd include also the range and then the level of variance. Any comments on that? Dan?
I think the median absolute deviation is useful and description of the distribution is useful. I would suggest taking out the IE outliers. We found in Senate Bill 860 that outliers are not particularly helpful information. In the shape of the distribution, I think that is useful, but your real outliers, I don't think they tell you anything that you really care to know.
Gary.
Yeah, I agree with Dan, because then you're going to get into the details of outlier, what's an outlier, things like that. I also had a question in that first part of the sentence, allowable reimbursement rates should include. Do we want to require them? And if we, if it should, if we don't, what happens? Just asking.
I think, the should is mostly because, right, like you can submit a median and then the range and then the deviation helps give clarity to like what that distribution looks like. So, we can talk about whether it should be reported along with the median, and maybe it should include is not the right language. It should, additional information about the median reimbursement rate should have, the range and then the deviation. But I think it gives clarity to what that actually looks like, distributed by the different provider groups, right? Because I think that's part of what this reporting element is trying to get at is, are there any difference between the different provider groups? What is that difference? And when you just have a median, it gives you one number, but having those, I think like the points of the range and then also the level of variance helps provide context to the median. Does that answer your question, Gary? Sort of.
Sort of. It helps being, like I said, I think if we clarify a little bit more about if we're going to do uncured claims or, potential, that helps me. But yeah, I thought that was a little odd, so I thought at least ask. Thank you.
Lisa.
So, so Gary, are you wondering if it should just be a different word used, like must include? Is that kind of what you were wondering?
Yeah, kind of.
Clear.
It should not. It just seems a little wish-washy to me.
Gotcha. Okay.
If it was an option for us, great. We can take it into consideration. If you're absolutely going to want to know it, great. Because sometimes my people are like, well, what's it going to do by providing high lows or deviations, things like that. So I think it makes it easier if you just say yes, include it.
Thank you.
Any other thoughts about number 1? I included the description of the distribution just so we know whether it follows, kind of a normal distribution or if it's skewed to one side or the other. Instead of, having everyone report like an interquartile range, which is way too far into descriptive statistics for this, but I think having that description will be enlightening to where the distribution falls. Number 2, I know we had some significant conversation about groupings, and we're almost at the end of our time. Also, it's almost 11:30. I'm realizing that. So what I put in rule was that the provider types are reported according to the groupings identified on the department's website. I don't know if that makes the most sense to have some flexibility if there are different provider types that come into the mental health space, or if we get into the reporting process and decide and kind of realize that the groupings need to be adjusted for whatever the reason may be. Wanted to kind of have that flexibility if that seems appropriate, but would love to get feedback. Gary.
Again, I put in there that it would, the groups would be identified by a specified date on the department's website. It just helps us. Otherwise, we have to go back and check it every week and worry about updates if in the rules would be posted on the website.
Yeah, we would definitely have it updated well before, if there were any updates, well before reports were due, for sure. But yeah, send that language to us. Melissa.
I apologize. My computer crashed, so I was gone from the meeting for a couple minutes. But I was just going to bring up what we discussed last time. I don't know if it's even relevant to this section or to another one where it may make sense to group providers differently depending on what comparisons we're looking at, because in certain situations it may not be necessary to separate all the master's level therapists, for instance, if they tend to be reimbursed at the same level. So that may be useful, having flexibility there.
Great. All right, we are at kind of our time in terms of allowing this discussion. We want to have some time allotted for any public comment. What I will say is if we don't have any public comment, we can definitely use the last 10 minutes to talk about some of these last remaining pieces. We will ask the RAC members to submit any written feedback to us by next week. And let's say like Thursday next week, because that gives us a little bit of time to review your feedback and talk internally about what kind of adjustments or edits we need to make to this discussion draft. Any kind of concluding thoughts before we move on to the public comment portion from any of the RAC members? Okay, so the pieces that we didn't get a chance to talk through are the time-based office visit reimbursement rates, and this is about kind of the reporting for the healthcare providers, as well as reporting kind of the percentage against the Medicare rate. Compliance with state and federal laws, if there's any information that we should specify in rule to help with that compliance piece, and any other data or information. So with that, I'll wrap up our portion for discussion, and we'll move on to the public comment portion. Is there anyone here that would like to provide public comment to the RAC? All right, I am not hearing anyone speak up now, but if you are an interested party and do have some public comments, you may submit those to myself or to Lisa, and we will make sure to distribute those public comments to the RAC group for everyone's consideration prior to our next meeting. So kind of in terms of just wrapping up here, like I said, we will, our next meeting will be on September 23rd. If you all have written feedback, in particular, even stuff that we already discussed today, if you take that back to your teams and get further clarity, please get that to us by Thursday at the latest so that we have time to take that information and kind of put that into consideration for adjusting this discussion draft. In our upcoming RAC meetings, hopefully we'll be able to also share some of the work that we're doing in regards to templates. If you all have any kind of information that would help with that, please send it our way. And I think that is all for today. Does anyone have any other questions or thoughts or concerns before we wrap up? All right. Thank you all for the conversation today. I found it very helpful, and we'll kind of keep plugging along for these reporting requirements. And then, you know, the second phase of this, once we get that all figured out, we'll be launching into the other pieces of the bill and making sure we get some clarity on all of the rest of it. So thank you for your time, and I hope that you all have a great weekend. Happy Friday.
Thank you.
Thank you.
Thanks, everyone.
Thank you. Yep.